Welcome back. It's the time of the show where we try to separate the fear from the facts out there. What is really happening when it comes to coronavirus and COVID-19? And there are a lot of things happening right now, including the reopening of the state of Texas. We are joined by Dr. Ruth Berggren from the Long School of Medicine at UT Health San Antonio, an infectious disease doctor, as we always are on Tuesday. Doctor, thank you for being with us. And
to be here.
When we're talking about the reopening of the state, the first question we have tonight is, are you concerned about the state's hospitalization rate, which is something we talked about a little bit at 6?
Yeah, so everybody's guidelines all point to the fact that when you ease restrictions, you want to be confident that there's been a sustained and very real decline in cases. And an important indicator of how many cases you have is how many people are in the hospital. We can get confused when we just look at the actual positivity rate, because that'll change as we target different populations. If we go and test all the nursing home residents, if we test all the people in the jail, we're bound to find more cases and more positives, and we expect to see some of those spikes, and we've seen them here in San Antonio. But not all those people are going to get sick, and anybody who's in the community who has virus and is getting sick with it and getting very sick is going to eventually land in the hospital, and that hospitalization rate is not going to be affected by targeted testing or ramping up testing. It's a real rate, and that hasn't really changed, Steve. In the last month, it's been very flat to maybe a slight uptick if you compare mid-April to late May. And that's data that is available for anybody to find it's publicly available data about hospitalizations in the state of Texas. So I'm concerned.
Yeah, that's clearly something you'd like to see on the way down, like the curve change.
Mm-hmm.
Yeah. The next question, now that testing's been expanded to include people without symptoms, who should get tested? This seems to be a very popular question. Who should get tested and why you should get tested?
Right. So we're recommending that people who are at risk for bad outcomes and those who are around them or who care for them should be the ones that get tested. And so we always start with older folks, anybody over the age of 64, or the people who live with those folks or who care for them. And then the other people who are at risk for bad outcomes are folks with poor health with respect to their hearts, their lungs, their kidneys, people with chronic diabetes, people who are immunocompromised for a variety of reasons. Those are the folks that we want to protect, and we should strategically have our tests done in a way that protects the people that have those problems. Healthcare workers should be tested. The people who go into nursing homes should be tested. And in fact, we've been working hard to get all the detention deputies at the jail tested as well.
All right, next question is about the president. The president says he takes hydroxychloroquine. Is this a good idea in your opinion?
What the president is doing is taking a medication that for an indication that we have no idea if it works for that or not. Hydroxychloroquine is a drug that I'm very familiar with. It has another name, Plaquenil. It's used to treat lupus, and it's used to treat malaria. Especially in places where there's still chloroquine-sensitive malaria. And it is a drug that has many uses, and it's a good drug. It does have its side effects, though, so we only use prescription medication when we know that the benefits are going to outweigh the risks. And the public needs to know the risks of hydroxychloroquine are not trivial, and they start with effects on the heart. So it can interfere with the electrical conduction system of your heart, which is how the rhythm of your heart is generated. And some people could get very dangerous heart arrhythmias, abnormal heart rhythms, which could even get serious enough for somebody to have a sudden cardiac death. The drug is toxic to the heart muscle itself. It also has myriad other side effects in certain people. Some people will have suppression of their bone marrow, so they can wind up with more immunocompromised state because their own bone marrow is not making the cells that it needs to make. There's toxicity to the eye. Long-term use of hydroxychloroquine can cause macular degeneration and retinal toxicity. So it's really no joke. It's a good drug when it's indicated and when the benefits are going to outweigh the risk. We have no good evidence that it does anything at all in COVID-19. In fact, there's a very real study that's very concerning that was done in our own veteran population with credible investigators from Virginia and South Carolina. And what they found is when hydroxychloroquine was used in veterans with COVID-19, they actually had a higher rate of death, a higher rate of death, and no improvement in whether or not they would need a ventilator compared to people who weren't getting hydroxychloroquine. Yeah. That study has limitations, okay? It wasn't a huge study, and it's retrospective. It's not a double-blind, randomized, prospective, controlled trial, but those kind of trials are actually being done. So the National Institute of Health is sponsoring a number of those. One just got started recently in San Diego. They're using the umbrella of the AIDS clinical trial researchers to study 2,000 people prospectively that have COVID-19, people that aren't sick enough to be in the hospital, but that are sick, and they're either going to get hydroxychloroquine and azithromycin, which is another antibiotic, or they're going to get 2 placebo pills. And they're going to monitor those folks going forward to see if this combination could possibly prevent hospitalization or death. So that just got started. There's another trial that's going on with the National Heart, Lung, and Blood Institute, and more that I'm not even able to rattle off. So we are going to get data. And I imagine it's going to be a matter of weeks and maybe months, but we'll have real solid information. Until that happens, I do not recommend that people take this drug.
All right, a lot of things are reopening. One of them, restaurants, bars. If a waiter speaks without a mask, will they infect my food? That's a viewer question tonight.
So I am of the opinion that waiters should be masked to the extent possible. The purpose of wearing a mask is to protect other people from getting the virus if you have it and you don't realize that you have it. First of all, the waiter shouldn't be at work if the waiter is sick, right? But the waiter should wear a mask because he or she might be sick and not realize it yet. Is it going to get on your food and then you'll get it from your food? There's no evidence that eating food is the way that the virus gets to you. It's much more likely that a respiratory droplet is generated as the person is speaking. Multiple little droplets kind of spew out from a person who's speaking. The louder they speak, the more droplets there are, and those land on your face, or you breathe them in, or they land on a surface that you then touch, and then you touch your eye or your mouth, and that's how you get it. There's been no evidence at all of transfer from a person to food and then to a person.
Right. All right. Final question tonight. When will we know if we reopen things too soon?
Yes. So there's a number of warning indicators. The warning indicators are a decrease in the time to the doubling of cases, an increase in the stress of the hospitals, so more occupancy of hospital beds, ICU beds, and ventilators, with lack of sufficient protective personal equipment or PPE. And then the other warning indicator that's important is to look at the percentage of the cases in a community that are positive. And right now we have seen a low percentage and a declining percentage. I think the last time I saw it, it was around 3.6% of the people in San Antonio who go to get tested for whatever reason are positive. Compare that to hotspots. There's a hotspot in Amarillo right now where the percent positive is about 10 times what we have in San Antonio.
Right.
So we want to be watching for those rises before they get out of control. And that would tell us we need to retreat back to more stringent restrictions as we had in the early days.
On a time frame wise, or do you think when we could first possibly see that? I think as a layman is guessing still we're like a week or two at least away from seeing those kind of indications.
Yes, I think you're right about that. Also, I think that not everybody in San Antonio is rushing out to ease those restrictions. And it's mixed, right? Some people haven't been taking it too seriously, but the majority have. Most people I talk to, Steve, are really very, very concerned. Even the restaurant owners, the folks who really want to get back into business. So I see in our community a rather slow easing of the restrictions, and I think it's going to be at least another week to 2 weeks before we see some of these indicators showing us worsening numbers.
Great information. Dr. Ruth Berggren, UT Health San Antonio, thank you so much for your time, doctor.
Happy to be here.
Thank you. We'll be right back.